You know, this is the beginning of my third year, so I've been here 2 years, so I'm afraid I can't say I'm new anymore. But in this time, I just want to recognize that a few things. One is that I've had incredible mentorship and an incredible welcome and support for 2 years. So I want to thank the incredible chairs, the clinicians, the staff, the nurses, everybody in the School of Medicine. I also want to recognize people that have really mentored me, like President Gerald, who's sitting up in the front, Roger Ward, our provost, Al Reese met with me monthly, I think bi-monthly before I came, and I think in all of these jobs we stand on the shoulders of giants, and I stand on the shoulders of Don Wilson and Al Reese, so thank you for your mentorship. My partner, the CEO of the hospitals, up here front as well, Bert O'Malley, who's really mentored me a lot, especially in the arcane ways of the rate commission and GBR, which I'll share with you. We also have many people from my board and fellow deans. We have many of my fellow deans here, so I want to thank you all for coming, and I very much appreciate your partnership with me. So with that, I'll mention things as I go forward, but I just want to thank everybody for being here. The goal of this event is to enable everybody within the silos of what we do to see the contours of the proverbial elephant. And by this experience, celebrate what we're all doing, but also try to break down silos. And so I'll go into some detail across our tripartite mission and our commitment to community. And part of that is I've found over time that the researchers love to see what's going on in the clinical front. The clinicians love to really know what's going on in the research front. And the same thing for education and community. And I think after seeing all this, you all can be incredibly proud of what you've accomplished, and also feel that your peers and partners are doing an incredible job. So this is really a celebration of you all. One thing about a dean is a dean doesn't really do anything. I feel like they probably do a little more than I do, but I feel like a switchboard operator or a communicator. So I'm really here just to communicate pride about what you all have done. So I'm going to go through a lot of information, and there's plenty of seats if you guys just want to fill in, and that will make more room. And I know there's folks upstairs. Good to see you there. So just some big news highlights. Tom Scalea is here in the audience, and I want to thank him and Bruce Poole, the chair of the board. And we can be very thankful and appreciative that we live in an incredible, progressive and committed state, the state of Maryland. And the state of Maryland's been absolutely committed to the University of Maryland Medical Center system and the school and to patient care across the state of Maryland. And they added a tax for all of our license plates. I'm about to get mine soon and pay my due. But that's really to support trauma care across the state. And so there's been a $41 million addition to our budgets for shock trauma. We are filling up and adding OR capacity and adding capacity. I think we've already, just at the start of this year, have a 7% increase in trauma volume as we're now able to accept more patients. So congratulations. We've also had incredible investments in our competitiveness as a state. And part of that is competing with Virginia for tech. And so with incredible support from Montgomery County, College Park, UMB, and University of Maryland Medical System, the state passed a bill to support the Institute for Health Computing. And as you can see, those dollars will ramp up for permanent support, again, to build a health computing infrastructure. We, as you know, I'll mention it later, but Tofika Wanikoko has come to fill the incredibly large shoes of Kevin Cullen, who's led our cancer center for years, but he's off to a very exciting start. He secured an $8 million partnership grant with AstraZeneca, which, as you know, is based in Maryland, to advance lung cancer CAT scan screening. And as you may know, it's been proven now that low-intensity CAT scans over the age of 50 in people that are long-term smokers can detect cancer, and the treatment of that can improve survival. So this has now been approved. But unfortunately, unlike breast cancer, where more than 95% of eligible people get mammography, for lung cancer, only 4% of people nationally are getting CT screening, and it's even less among Black Americans who are at higher risk for lung cancer. So this is an exciting partnership. Everyone's read that we completed our second historic xenotransplantation. This slide is really just to recognize the almost 200 people across the system that participated in the 40 days of care of Lawrence Fawcett. Everybody from the people cleaning the ICUs to our nurses, our respiratory therapists, our anesthesiologists, our nurse anesthetists, our surgeons, our consultants, our cardiologists. We tried to send a thank you email, and it was overwhelming the number of people that had touched his care and felt passionate about the care that they'd given him. And I just want to recognize him as really a hero in science and medicine. He's like an early Apollo astronaut. You know, he knew the risk he was taking. He committed to doing this knowing that he wanted to live a few more days and hopefully that his life would contribute to science. So we also recognize him. Again, feel free to come in and squeeze in if you want. There's plenty of seats. Bart Griffiths just walking in on cue. We also have created a new department. We had 2 departments of pharmacology and physiology, and we had a white paper by the faculty who felt the strongest move forward would be to combine and create a stronger department. So we've created a new department of pharmacology, physiology, and drug development, which will align 3 divisions: cancer therapeutics, considering our historic contribution to cancer therapy through aromatase inhibitors, molecular physiology, and neuropharmacology. And we're very appreciative Dr. Stuart Martin, who's also the Deputy Director of the Cancer Center, Stuart, who will be leading this department in partnership with Tom Blampede. So just some numbers, where are we? First of all, US News has a new rating system where they're rating things in tiers, tier 1, 2, 3, 4, and unranked. And we've now been ranked in the tier 1 for primary care. And that places us in the top 15 of 192 medical schools, including elite programs like UCSF and UC Davis. We're also have been ranked in tier 2 for research. This is the top 40 of 192 medical schools, including a number of them listed there. And again, very few schools are ranked in both tier 1 and tier 2 for primary care research, because often if you're strong in primary care, you're not as strong as research. So I think you all can be very proud of this. In terms of AAMC, which monitors federal funding, you can see on the left we're ranked 32nd among all medical schools, allopathic medical schools, and 13th among public medical schools, but we have less faculty. And if you look at our funding per CFT or per faculty member, those numbers are 26th and 9th. And again, something we're investing a lot in the research enterprise and expecting, as you'll see in a minute, this to grow. These are our departments that are ranked highly in Blue Ridge. Now, Blue Ridge only captures NIH grants, and we have a lot of DARPA, DOD, Public Health Department, PCORI federal grants, which aren't captured in Blue Ridge. But anyway, congratulations to the many departments on this list. So we've recently completed a strategic plan, and many of you have heard about it. We've sent electronic versions of this. If you haven't received it, please let us know. But we're calling this GenMD for solving generational health challenges of our time. Now, what's important about this is we launched this coming out of COVID, and the LCME accreditation required us to have a strategic plan. But we wanted to make sure that in activating this strategic plan, we improved engagement. We were hearing from surveys that people felt disengaged after COVID, again, in silos, zooming in. So a big point of this was to hear you and your voice. So we actually had, led by Wendy O'Donnell, 40 grassroots brainstorming sessions with departments, centers, large divisions, and then 2 community-focused engagement events. Ultimately, 969 faculty, almost 66% of our faculty, participated in one of those events. We then followed that with prioritization meetings where we pulled out what we heard from you and prioritized those messages, and then 4 working groups to come up with a written document. And ultimately, this was 9 months of engagement. From this, we have a new mission statement, and I'll just read this. I really love this. We pursue excellence across biomedical research, education, and patient care to advance health equity and wellness for people in Baltimore, the state of Maryland, and around the world. Together, we work to solve generational health challenges and make lasting contributions to the betterment of our diverse and interconnected communities. And our vision is to stand as one of the nation's leading public medical schools, distinguished by an unwavering commitment to fostering vibrant and healthy communities through bold discovery science, transformative education, and personalized, equitable patient care. While we all focus on the day in and day out work of our research, and the individual contribution to research ultimately across time and space has the biggest impact, we also try to think about how we can come together to address generational challenges. And these are the generational challenges that we've listed in our strategic plan, and the obesity epidemic, the aging of our population, emerging pathogens with antibiotic resistance, zoonotic infections, the emergence of climate medicine, mental health and addiction, health inequity, brain diseases and neurodegeneration that are really an epidemic now following aging, and then the disruption of AI and big data. And you'll see as I go through this presentation, we're hitting most of these and very successfully addressing most of these. So within this strategic plan, from these meetings, we pulled out the classic tripartite mission, education, research, and clinical care, but also added community, considering the privilege and responsibility of living in West Baltimore. And for each of this, developed a strategic plan that came from your voice and your feedback. And this is just an example of an open 2 pages of the book for community. But what I wanted to point out is the orange are actually the strategic priorities that we heard from these meetings and prioritized and synthesized. And then from these, we pulled out goals and objectives. And I won't go through these, but the objectives are very concrete, things we are going to do together. And we're now going into implementation, and our vision for that is a top-down and bottom-up implementation plan. And these are our working group leaders shown here. We appreciate all the hard work they have done throughout this process, and we'll be tracking progress through milestones, and I think we're already making a big impact across the strategic plan. And then we also want to engage the faculty in this process. It could be a great opportunity for leadership, putting things on CVs, again, being part of how we change this university. So let's talk about research. First of all, we have a number of new research directors. I think right in the middle, we have Dr. Dunn and Dr. Fertig. Hello. We'll mention more, embarrass you more later. So we also have interim research leaders, Deanna Kelly, Sham Kodalil, who's been really working hard in turning around IHV in partnership with Man Sherirat, Dr. Laufer, Dr. Martin, who I mentioned, and Dr. Wilson, who's leading biochemistry. The way our interim leaders are serving is they're serving as active chairs. They are recruiting, they are building, they are engaging. So these are fully activated or fully supported chairs. So these are grants and contracts numbers for 2024, and you'll see they're flat, but this is actually really good news in that we have lost over this period of time PEPFAR funding. We received almost $120 million a year of PEPFAR, which is the CDC funds to drive care in Africa, HIV care in Africa. So when I first came here, Louisa told me the biggest threat to your next first 2 years is the loss of PEPFAR. So I think it's absolutely incredible that we've held this funding stable. The other thing we're seeing is submitted grants are way up. And this is a testament to how hard our investigators are working. So we're seeing a 10% increase in submitted grants and contracts, which suggests that these numbers are going to grow. Just a few big grants. One is this very large $3.5 million a year BARDA grant. That's the Biomedical Advanced Research and Development Authority, led by Erica Davies. Within our radiation oncology department, we have a good laboratory practice, GMP, large animal and radiation therapy research program. Only one of 3 in the nation. And this is intensely focused on mitigating radiation injury, which we now know is a major national priority, especially after Russia's invasion of Ukraine, where it became very apparent that nuclear power plants, which are key to a sustainable future, are a vulnerability. So this is incredibly important research, and we expect to get this grant every year, totaling at least $16 million. Antibiotic resistance is one of our emerging generational challenges, and our Center for Vaccine Development has many leaders in this space. And Sharon Tennant secured a $3.95 million grant to try to combat antibiotic-resistant bacteria. Malaria, the CVD are also leaders in the development and testing of malaria vaccines, one of the leading killers on the planet Earth. And Matt Lawrence secured this $49 million over 5 years to conduct a randomized dose escalation phase 1/2A trial. Phase 1 is first in human, and phase 2A is seeing if it works. Jonathan Bromberg, probably one of the most decorated and successful physician scientist surgeons, who was inducted last year in the American Association of Physicians, secured an $8.5 million grant studying exosomes and looking at these as biomarkers in transplantation. Sarah Catacuzzi secured an $8.75 million NIH contract called the CHOICE study, and this is looking HIV-infected patients that are hospitalized with IV bloodstream infections from IV drug use. So a very vulnerable population, and how do we improve the care of these patients? I also want to recognize Dr. Drake isn't here, but she launched an incredibly innovative program, and every month she would meet with me and say, we've got to do this, we've got to do this. And she did this on a shoestring budget. And what she did is there are these grants called diversity supplements. And they are grants that you can apply for as a postdoc or a young faculty member, but you have to be part of a PI's grant. But that diversity supplement is only almost $600,000 over 3 years, which supports salary and research. And she said, we need to get these diversity supplements. So what she did is she did 2 pathways. And by the way, the number one complaint I hear from our investigators, we can't get great postdoctoral fellows. Not enough people are becoming postdocs, so it's hard to recruit talent. So what she did to solve both problems is she got a list that Yale has been curating of top 200 URM PhD students from the top elite labs with high impact papers. And she went through that list and she matched them to PIs that she knew and met here at the University of Maryland. And then if there was a match, she would bring in that PhD individual as a postdoc and called them a research associate, and they would mentor them to write the diversity supplement. She also identified people in all of your labs that would want to write these diversity supplements. So 22 were submitted in the last year and 17 were awarded. 17 $600,000 grants. There's 5 in the research associate track and 12 that were internal already. And the bottom line is $4 million in funding for these young stars. And again, bringing talent, attracting talent to Maryland. One of the key issues of research is building and supporting that next generation of scientists. And you need grants to support those scientists. And we currently have 14 T32 grants, which train graduate students or postdoctoral fellows. 11 R25 grants, which train people for research during their educational stints. And then 2 D43s. And we got, in the last year, 4 new R25 grants, and the PIs are shown here. We've submitted 2 D43s, which trains people for research in low and middle income countries. We submitted 2 K-12 grants, which are institutional funding for scientists as career development awards. We've submitted 2 new T32 awards and 3 new R25 awards. So just an incredible activity. And this is really a passion project because you don't receive much effort to put in a grant like this. So we've added incentive of a 10% effort to anybody that leads one of these grants to, again, recognize the hard work and commitment to training that these PIs are following. So I'll just share with you a little video.
As a pulmonary critical care specialist at the VA Medical Center, Dr. Mary Mulderelli is helping veterans to breathe better.
Looking at the CT scan, everything looks really good.
But she is also a physician scientist, conducting research to better understand the conditions she treats.
To me, being a physician is fundamentally the application of science to help other people. And so if you are applying science, you should be doing science. I always felt better knowing that I could go back to a lab to answer more questions about the patients. You can make discoveries that help more than one person. You can help whole groups of people, which is the great value of research.
Dr. Moldarelli is receiving research training through a T32 fellowship while collaborating closely with Dr. Brad Marin and his team at the University of Maryland Institute for Health Computing.
There are data analysts, there are programmers, there are statisticians, we have an economics expert. There's a whole team of people who have a lot of experience in data and big data research. And so you can pull on different expertise from different people. I've called it a brain trust often, of very bright, wonderful people who have made incredible advances in their field, who are now all put together in the same space, and that is the best way to promote collaborative research where we can really make a difference.
In one of their first projects together, the team was able to show that smoke from Canadian wildfires caused an increase in cardiopulmonary patient visits across the University of Maryland medical system.
So that allowed us to figure out how are we going to extract information, how are we going to house it safely to protect patient information, and then how are we going to get our data off of that safe space into a place where we can publish it. And so it was a great opportunity to kind of test the system.
We also just want to recognize some of the exciting high-impact publications coming out from our faculty, and these are just the list of high-impact journals that our faculty are publishing in the last year. And just to shout out publications in JAMA Network from Anthony Harris, who's characterized the prevalence of highly resistant pathogens in our nursing homes and healthcare settings. Sean Quatra, who has identified a new therapy for patients with intensely pruritic or itchy skin, and he's building an itch center. Matt Lorenz with a single-dose typhoid. I told him he needed a better name than Itch Center, but if you have any ideas. The typhoid conjugate vaccine. Our group completed a clinical trial of a new phase 1/2A trial for sickle cell with Rio Sigua. Seth Ament has Science Translational Medicine is one of the most prestigious basic science journals, and he's characterized brain inflammation in children can cause later neurologic disorders. Paola Corti discovered a link between a hemoglobin-like protein, cytoglobin, and normal cardiac development. And Jared Slobosian, I don't know if he's here, or O'Toole, or any from the team with Nathan O'Hara and the group on the right, published this paper in the New England Journal. Now, there's a very famous physician ophthalmology TikToker, and he explains complex things to people. And so in this TikTok I'm going to show you, he plays an orthopedic surgeon and an infectious disease doctor, which he calls, I think, a bug doc or something like that. But here it is.
Hey, Ortho. Oh, what up, bug bro? Did you see the new study in the New England Journal of Medicine about preoperative antisepsis? Nah, bro, I've been pretty busy over here. Oh, okay, well... It involves fractures. I'm listening. We randomized over 9,000 fracture patients to receive preoperative iodine or chlorhexidine. Different types of topical antisepsis. And cephalotion. Oh, cool. Anyway, turns out the iodine group had fewer surgical site infections. What kind of extremity fractures were these? Were they open or closed, bro? Bone sticky outie. Oh, both were included in the study, but only the closed fracture group was statistically significant. So according to this study, it would be best to prep all my closed fracture patients with iodine? Yeah, you should also carry around an antibiogram. Here, I brought an extra. Oh, I already have one, thanks. Oh, okay. Well, see you later. Later, bug bro.
So congratulations. TikTok, I think, is going to be illegal soon, right, President Gerald? So anyway, we've also are launching, we're looking for ways to incentivize our faculty and reward our faculty and get compensation up, frankly, for our faculty. And we're really appreciative of the University of Maryland, Baltimore, who's allowing us to access indirect funds to support you. And so this has been support from Bruce Gerald, Don Rhodes, Scott Bittner, Alana Karyakakis, I know you worked for so much time on this. Thank you. Now, this incentive, you determine who's eligible, and then you get an incentive based on other parameters. But people that are eligible are full-time researchers, physician scientists, or career development awardees. You have to be assistant professor or above, and you have to meet target salary coverage. So if you cover 60% of your salary as an assistant professor, you're eligible, and we're paying, by the way, for last year to assistant professors, 70% for associate, and 80% for full, and that's of the research component of your salary towards the NIH max. And you'd have to be a PI or multi-PI. But then if you hit that, you get $5,000 for all career development awardees, even though they have low indirects, and then 10% of indirects that are expensed as PI or co-PI and capped at $30,000. And again, we've spent a lot of time, so I'll go over this quickly. And this is in addition to any consideration of merit that would come from the state. Now, why do we do this and why do we all win? Well, one, it's an excellent recruiting tool. Second, it can increase our salaries and reduce flight risk. It stimulates collaboration because you want to get your effort over those targets. So people want to add the 5 and 10% on each other's grants or partner on grants. It increases grant submissions that have higher indirects because it's only for grants with 26% indirects or higher. And that will incentivize NIH grants, which have higher indirects. And also, we're going to give credit, I think 10% will be the plan, for major commitments like the IRB and the IACOC. We've also been focused on entrepreneurship, and we're very proud that Jason Rose and Jim Hughes secured a Build grant. This is one of a grant that only went to 5 states across the country. You can see them listed there. It's $4 million to create a hub that invests pilot in startup companies. And so we're very excited about this, and this is launching. We're also creating, with our board of visitors, many of whom are here today, a innovation alliance. And the idea is to bring together venture capitalists, angel investors, home offices, people experienced in drug development into this network that would then advise us on the evolving IP coming out of our university. And we appreciate Santosh and Marco for leading this effort and people that have already joined this alliance. So if you know people like that to be interested, please let us know. So let's talk about our institutes and centers. So these are updates. The Institute for Health Computing, you all know about. They now have 70 employees, many people in your labs, students, trainees, PhDs, physicians, or professors that are there full-time or part-time. They've moved into 27,000 square feet of beautiful space in North Bethesda. We've completed, it took probably more than a year, a master agreement between College Park, UMB, and UMMS, our partners. There's been 60 papers published in high-impact journals, and the group is working very hard in collaboration with the Collard Institute for Addiction Medicine, with a lot of support by Michael Cryer, thank you, to advance an Advanced Research Projects Agency for Health, ARPA-H project, to try to prevent fentanyl overdose in Baltimore. And we're very excited about this project. We've lined up collaborators from the Rate Commission, the mayor's office, pharmaceutical companies. Hopkins has joined us. Very excited about this $47 million project. And we just are about, maybe this week, Alana, signing an agreement with NIH that we're going to have National Heart, Lung, and Blood Institute scientists coming and be embedded in the Institute for Health Computing. Again, these are our leaders, Brad Marin, Warren D'Souza, and Adam Porter has joined as a co-executive director from College Park, and he's been a wonderful partner. These are the areas of focus. We already have people working on therapeutic target discovery and silico target discovery, population and community health, leveraging the 2 million patients that we care for in the electronic healthcare record across the state of Maryland, and trying to develop new adaptive, pragmatic, randomized trial in the EHR. That's probably the most challenging piece, but something Brad Marin and Warren are working hard to achieve. So we want to welcome Dr. Dunn in the middle. Can you wave, Kelly? Dr. Dunn is joining us as the new Institute Director for the Collard Institute for Addiction Medicine. She's a PI on grants totaling more than $21 million. She has 130 peer-reviewed publications on substance use and opioid use disorder. She does very cool translational research where she brings patients on opioids, like buprenorphine, and under observation stops their opioids, but at the same time randomizes them to experimental therapy or placebo. And for example, she just published, again in that high-impact journal, Science Translational Medicine, a study looking at suvorexant, a drug that modulates sleep. And she told me that you couldn't blind those patients because it was dramatic. The people that got it had no craving, no withdrawal. So imagine if we could develop drugs like this that could maybe bend the curve of opioid use. We also are delighted that Mary Kay Lobo, is Mary Kay in here? Mary Kay is probably the most funded individual scientist in Maryland, if you don't count big grants like the CTSA. She's PI in 3 R01s, a U01, an R33, and a basic scientist really trying to study interventions for addictive drugs. And she's taken the role of Associate Director for Basic and Translational Medicine in the Collard Institute. So congratulations to both of you. Obviously, this is an enormous generational challenge, and this is very personal for us in Baltimore. The data show that Baltimore has the highest per capita fentanyl overdose rate in the nation. Many of you read the articles series in the New York Times and the Baltimore Sun, so obviously an important challenge. The Collard Institute is looking to tackle this from basic science to the clinic. We have 62 active grants, totaling more than $112 million already at the University of Maryland. There's an intense focus in our Department of Psychiatry, led by Eric Weintraub, on harm reduction, treating people with buprenorphine or methadone, and these are all our treatment sites shown on the right. We have county detention center treatment sites, mobile treatment units, telemedicine treatment, and of course our large treatment center in West Baltimore. And then again, new discovery. Graham Woodworth, Linda Chang are working on focused ultrasound to try to turn off addiction. Again, we're excited about the new work that Dr. Dunn will bring to us. We also have had great gifts, not only the Collard Family Foundation giving us $10 million for this effort, but a major gift from the Osborne family, which is launching a new fellows program for people that want to build their careers focusing on addiction treatment research. And Dr. Weber and Olusakin have joined us. And finally, very exciting, Sarah Catacuzzi and Collard joined the Appalachian Clinical Trials Network node that's led by Pittsburgh. And this is a NIDA, National Institute of Drug Abuse Clinical Trials Network. And there's nobody in Baltimore that's part of this network. So we joined them, and the grant got an impact score of 16, and so we'll become a network member this December. So that's an important accomplishment for the Collard. And the space is, I think, started. So this is going to be the 5th floor across the street where we're going to have our reception of HSF 3. And this is the breakdown. It's exciting because there's going to be space for animal behavioral work, space for patients to come in, and then wet lab research space to build the Collard. And the group is actively recruiting investigators, as you saw in that last slide. So I want to have Michael Spites talk to us for a minute.
Michael Spates is rebuilding his confidence and self-esteem, working as a carpenter again after years of substance abuse. Michael is renovating a row home in his own neighborhood, where he once bought drugs on the street while hiding his addiction from family and friends.
I've always had issues with my mother, things that I never dealt with. Father, I felt that I was a little abused, things like that. And that was an escape for me when I actually started experimenting with the drugs. A little bit of pot first, a little bit of alcohol, and then started sniffing the heroin, and I was off to the races then.
When he crashed a co-worker's truck while high on heroin, Michael finally sought help at the University of Maryland Addiction Treatment Center in Baltimore.
What was it like? It was humiliating, embarrassing, scared, a lot of fear.
Drug use had taken a heavy toll on Michael's body and soul, but he's turned it all around thanks to the help of psychiatrists and counselors at the treatment center.
They hit me hard. The truth. And you find out, when you get somebody that you know somebody really care about you, no bullshit, and they really care, for me, it's like, oh, it's possibility that I could be happy.
In more ways than one, Michael's addiction treatment was truly life-saving because it also gave him access to health insurance and primary care. Luckily, doctors found and removed precancerous polyps before they became life-threatening, and his teeth, lost to years of drug use, have been replaced with a brand new smile.
You just got to take the first steps and just let somebody help you.
Mr. Spates, we appreciate your courage and resilience, and you're a role model to all of us, and maybe you could just stand up and we can applaud you. So the University of Maryland Medicine Institute for Neuroscience Discovery, which is led by Peg McCarthy, Peg, and supported by all of these chairs below, is off and running. They're actively recruiting scientists. They've obtained a super resolution microscope. For the scientists in the room, they know the Nobel Prize was awarded in the last 10 years, I believe, for the science around super resolution microscopy. And Tom Blampied leads this effort. This is called a STED microscope. And if you look, a traditional confocal image is shown on the top. I think these are brain slices. And on the bottom is with the STED instrument. And you can just see that with super resolution, you can actually see inside cells and look at subcellular proteins, organelles, and their interactions. So really remarkable technology is available for the university today. And this is also being built, this floor, so an entire floor for neuroscience. So we're very excited about this. I had mentioned Tawfiq joining us. I just want to point out that he's our new executive director of the University of Maryland's Greenebaum Comprehensive Cancer Center. He's internationally recognized for lung cancer, in particular biomarkers of small cell cancer and clinical trials around small cell lung cancer. And he has more than 250 original research articles and is a leader in national cancer organizations. So he's off to the races with recruiting as well, the Cancer Center. He, Stuart Martin, the faculty have already recruited 6 principal investigators since January. And I just want to highlight the first person. I'm not sure this has been announced, so maybe this is a secret still. But Dr. Law, sitting back there, and Tawfiq have recruited Jeremy Davis from the National Cancer Institute as a physician, scientist, surgeon that will be leading surgical oncology here. So congratulations, Dr. Law. And all of these investigators from Rutgers, University of Pittsburgh, Johns Hopkins, Sloan Kettering, NCI. I also wanted to just share with you, because we don't talk about this a lot, but I just spent 7 days in Nigeria earlier in the month. And we are one of the top global health universities in the nation. I don't think we promote this enough. These are all the sites across the world where we have active clinical trials and clinical work through the Center for Vaccine Development and through the Institute for Human Virology. And this is Miriam Laufer at her Malawi Research Clinic. I saw her somewhere up there. She is. Hello, Miriam. And but she gave me sort of the highlights, the great highlights of the Center for Vaccine Development. And I think Mike's here somewhere as well, Mike Levine. Developing WHO policies for malaria prevention in Africa, developing and licensing vaccines for cholera, non-typhoidal salmonella, and Shigella, leading studies of vaccine implementation across Africa, Asia, and Samoa, treatment of emerging antibiotic resistance, like that grant and those papers you heard about, and developing new vaccines for malaria, like those phase 1-2 studies you heard about earlier. The Institute for Human Virology, again, I was able to visit Nigeria. There's an entire tower, research and clinical tower in Abuja. But over the last 20 years, through the leadership of Bob Bredfield, Bill Blattner, Bob Gallo, Man Cherirat, almost $1 billion from PEPFAR, which was the George W. Bush-funded effort to try to bend the curve of HIV, flowed through the University of Maryland, UMB, and over that time, in 20 years, 30 million people in Africa have been screened for HIV. 9 million have been treated, 50,000 healthcare workers have been trained, and 25% of all the people in Africa that have been tested and treated have been through this partnership with HIV Nigeria and with IHV, through IHV Nigeria, excuse me. And this is just some pictures from this visit. So Clement Adewu and Tofika Wanikoko and I went together and joined our faculty there that are shown in these pictures here. But we gave seminars on emerging non-communicable diseases like cardiovascular disease and cancer. This is touring the IHV. We went with Sham Kodalo as well. There you can see Clement. This is an ICU that we saw in Abuja. We went to the Cardiology Research Center and heard grand rounds on sickle cell disease. We went to the special treatment units in Abuja, which were amazing for patients, very vulnerable patients that are LGBTQ living in Nigeria with HIV. And there's an incredible treatment center there. We also went to wealthy locations, new modern cancer treatment sites in Lagos. And there was a common theme. They're very interested in our training medical oncologists and radiation oncologists. And this is a sickle cell center, beautiful sickle cell center that we went to. And I'm also very proud that we have faculty from Maryland that are based in Nigeria, Nigerians, Patrick, Charles, Lashni, and they are tenured investigators from the University of Maryland working in Nigeria. So it's really a partnership. And so what we're looking to do is now expand this partnership from traditional HIV towards non-communicable diseases like cancer, cardiovascular disease, and sickle cell. So we also want to welcome Dr. Fertig, sitting in the middle. Elena, she is our new institute director for the IGS, Institute for Genome Sciences. She's been a PI or co-PI or core lead on NCI consortia grants totaling 30 million, 130 peer-reviewed publications. She's recognized for integrating, she's a mathematician, had a PhD in math from College Park, and recognized for integrating spatial multiomics technologies with math models for new predictive medicine paradigms. So welcome. We're also delighted to announce that we're going to create a new center within IGS, the Center for Advanced Microbiome Research and Innovation. This will be one of the larger microbiome centers, and I'm absolutely delighted that Dr. Jacques Raval has agreed to lead this. This will be a hub for pioneering discoveries and innovations to translate microbiome science into tangible health solutions. He'll also have a new Dean's Office leadership position, driving research leadership out of the Dean's Office. And you all know he's one of the most funded investigators at the university with the U19, R01, R21 grants. So congratulations, Dr. Raval. We are creating a new partnership with College Park. You've heard about this before. It's a bioengineering collaboration. This will be a center for translational engineering in medicine. This will make us highly competitive for federal funding, having College Park here in the health sciences environment. The goal will be to understand real-world needs for clinicians and patients and a faster pathway for tech transfer, because Jim Hughes on the adjoining floor is building an incubator lab at the new iconic Wexford building for MLK.
A truly impressive addition to the West Baltimore skyline, 4MLK is nearing completion and soon will provide state-of-the-art research space for an exciting collaboration between University of Maryland School of Medicine physicians and bioengineers from the University of Maryland College Park. The Center for Translational Engineering in Medicine will occupy the entire fourth floor of 4MLK, allowing face-to-face collaboration to address a wide range of generational health challenges.
For the longest time, I was driving down to College Park once a week to meet with the scientists over there, collaborating with people over there. And so that's inherently a barrier, right? So now you can literally just come across the street to this world-class space, and you can have a cup of coffee, you can interact with the scientists here, and they can really also have time in the clinic or in the hospital understanding the real-world problems of our patients. And I think that really, that's something that you cannot really do virtually. That's something that's not something that you can substitute.
When complete, clinicians and scientists will share new lab and office space. Bioengineers will develop novel devices and technical solutions to help clinicians solve vexing problems and speed new treatments to their patients.
I do imaging, for example, and so my imaging devices, my spectrometer, the laser, endoscopes, they're naturally applicable to clinical studies. Anything that is that can be interfaced with the medical school will be prioritized.
Really what we're envisioning is a great interaction and fusion between everybody in this space and the campus at large. And so that could be ranging from people who have interesting questions on imaging analysis, on radiology or ophthalmology, for example, or really leveraging the strengths of our cancer center or other strong clinical programs.
So this was just filmed about 3 weeks ago, so this is really what that floor looks like. So it's moving very rapidly. So as you've heard, we have an incredibly competitive medical school. I heard from Sandra, we now have more than 7,000 applicants right now for this year for 165 seats. Our class of 2028 had a 90th percentile in the medical college admission test, an average GPA of 3.83, 57% women. 71% of our students are from Maryland, and 28% are underrepresented medicine by NIH definitions, which includes socioeconomic status, and come from 61 different universities. Our class of 2024 that just graduated was the first to go through the revamped Renaissance curriculum, so congratulations to the teams that built. That's a organ system approach to medical learning, but their Step 2 scores have risen. There's, on surveys, improved perception of basic science and the relevance to clinical work, improved emotional climate for our students, less feeling of burnout. And for the first time in many years, 100% of our students matched to residencies. And this is an incredible pathway or pipeline to physician talent in Maryland. 25% stayed here at the University of Maryland Medical Center. 36% matched and stayed in Maryland, and 44% are in primary care specialties. And you can also see our students are matching competitively when they want to leave, hopefully not that often. They are incredibly competitive. We went through accreditation. There's a liaison committee on medical education that reviews us every 7 years. They came April 16th. We had a positive preliminary exit report. We get the final report in October. Our group spent more than 2,000 hours working on this. So it's just an enormous effort. And through this, we revised our bylaws for more engagement. The strategic plan was required by this. We completed the strategic plan, and we re-engineered more rapid, efficient appointment process for volunteer faculty. We're also launching a new program called RHEAL, and this is the Rural Health Equity and Access Longitudinal Elective. And I went to, with Bruce Gerald, Mohan Suntha, and others, Isa Davis came. We went to the Eastern Shore, and I spent about 7 days touring, meeting with delegates, philanthropists, alumni, to really obtain commitments to fund full scholarships for this program. But the vision for this is students will train here in Baltimore for 2 years and then spend 4 months of each year in the third and fourth year on the Eastern Shore. And then if they receive full scholarships, would pay back by service on the Eastern Shore. So the idea of how can we expand our med school to address unmet need. And just a shout out to our graduate students. We have more than 363 students working on their PhD. We have 265 postdoctoral fellows who are doing fellowships after obtaining their PhDs. And they're very successful, like Sam Barlow here, who received this $50,000 first place prize from Regeneron. We also have an incredible genetic counseling program. This is, they caught me at the solar eclipse with the glasses, but these are the students in this program. We have 10 students per year. There's a 4% accept rate. They had their 25th graduating class. And if you look around the nation, most genetic counsel leaders come from this program. In fact, most of the genetic counselors at Hopkins graduated from this program, so very successful. And this is a really important field as genetic medicine advances. Physical therapy. I saw Tori Marchese in the middle. She has 70 students per year in a very competitive 3-year Doctor of Physical Therapy program and has introduced a new value-based learning curriculum shown here. And I just want to share with you one of their very innovative educational programs where the patients are the teachers.
These physical therapy students are learning about the special challenges faced by patients with prosthetics. The teachers are the patients themselves.
There's no such thing as an amputee is an amputee is an amputee.
The session is part of the Patient Educator Program, which has been part of the University of Maryland PT curriculum for decades.
There is no substitute for a live patient at the end of the day. So even the best faculty role play, the best student role play, there are just certain things we cannot mimic. They get to experience the condition, they get to put it's more holistic because it's now a person and not just a case that's on a piece of paper. So they get to see all aspects of the case and really understand how, whether it's age or their condition, impacts all aspects of their life.
David McCrae is a longtime patient educator volunteer.
This is the front line. These students will be the ones who will impact and have a great effect on new amputees or people like myself that have been an amputee or worn a prosthesis for 60 years. So knowing that you can really make a difference in their education, there's so many different factors. And helping these students understand as many factors as we can through the range of the educators that are brought in can only be to the advantage of all amputees moving forwards.
Carol Hyman became an amputee 2 years ago when she was struck by a bus during an anniversary trip to London.
Part of the challenge of being an amputee is a loss of confidence. And I think the more I meet with people and can talk about my story and my journey and answer questions, gives me more confidence. And that is such a big part of my rehabilitation.
The students are grateful to have the unique perspective that only patients can provide.
To be able to talk with these folks firsthand and learn about their experiences and how the healthcare system has helped them, I think it's making me a better practitioner and helping me prepared for the future and seeing real life cases like this.
That kid is quick. Clinical care. So again, we have incredible chairs, and I appreciate our new clinical chairs, Frank Henn, Lisa Shockett, Sean Quatra, who's joined us from Hopkins. Welcome, Sean. And then our interim chairs. Sam Galvano has been working so hard in anesthesia, as you'll hear. Paul Statz in the Department of Pathology. And Bill Regine, we have tasked him, not only does he have to be the chair of RADONC and the president of FPI, but briefly, only briefly, he'll have to be the chair of radiology. So thank you, Bill. We also have a number of new administrative leaders. Jeanette Gibbs, partnering with UMMC in ambulatory services, and I'll mention some of the other folks as I talk about FPI. So these are the patient care numbers. It's pretty amazing. We see 2 million patients within UMMC and across our outpatient services. And you can just see the numbers of cancer patients treated in the upper right, cancer outpatient visits, orthopedic trauma, baby delivered, transplant surgeries, and the same thing, 49,000 or more ER visits. Really remarkable. We have sort of energized and reprogrammed the faculty practice, and I want to give you an update. Our faculty practice reports to the Dean of the School of Medicine, to President Gerald and the Board of Trustees, and also reports to our chairs, to the chairs of the board of the practice. We've recruited Rachel Hoover, who's our killer, who is our Executive Vice President of the Practice Plan and Chief Administrative Officer, and she's been doing an incredible job. And below, we have all our leaders within FPI who are incredibly talented. I could say a story about all of them. I just heard the other day about how Caven helped negotiate all our payer contracts, and I just really appreciate everything that our leaders in FPI do. Our practice now sees more than 1,000, or has more than 1,300 physicians within it. Our practice sees, again, 2 million outpatient inpatient visits in 2024. We represent 40 medical specialties and 95 practice locations across Maryland, serving at UMMS, serving in clinics at UMC, at Midtown. These are just some data. In 2020, there was a drop. In blue, we have collections. So these are bill collections. which had dropped to 250 million per year, and those have gone up by 9.5% by 2024, as you see in blue. And there's a little delay because of the cyber attack. On red, you see the increase in patient visits, which approximates now 1.7 million patients. Now, under Rachel and Bill's leadership, we have had some major successes in the last year. One is payer negotiations. Our payer rates going up almost 30%. Right now with 2 payers, I'm not allowed to say which 2, but I think 3 more are on the docket for negotiation. We have brought in our nurse practitioners, which I do want to mention a bit, to partner with our faculty. Under the leadership of Frank and Graham Woodworth, we have launched and revitalized our ambulatory surgical center, I'll mention that, and created an entire novel for-profit arm of the faculty practice called the Faculty Physician Enterprise, with the idea that we could bring in elite private groups to be part of our family, and then those individuals would refer and partner with us and the UMMS system. This is the ASC at Waterloo, and this was a grand opening. You can see Steve Ludwig, who's really played a major leadership role in this, Graham Woodworth, LK here, Lisa Shockett, and Bill Regine, but we're very excited about this, and I appreciate all your leadership. This surgery center was losing $1 million a year, and 2 months after opening has flipped to cost neutral, and Graham assures me we have a profit soon, right? Yeah. We're also very proud and excited that we're bringing our nurse anesthetists into our faculty. We brought them to be partners in our faculty. And this was in the shock trauma ORs. That's me, that's Matt D'Angelo, who Sam Galvano recruited to be the new division chief of our CRNAs. And these are 3 of our CRNAs, their names are below, but they were teaching me tips on fiber optic intubation. They're real experts. But bringing them in this integrated model, we really appreciate Kevin Steer, our SVP for perioperative care, who helped lead this. And we've really improved the collegial culture, where our CRNAs are going to serve at the top of license as providers, and we see it as a true partnership, and that's helping us recruit. So over this time, under their leadership, in 6 months, we've hired 16 CRNAs, which, as you all know, is very hard to do. Including 11 new graduates, and our vacancy rate has dropped to 12% from 40%. And some of the strategies are shown here. This also includes enhancing our partnership with the School of Nursing for their CRNA program, which is really world-class. So thanks, Yolanda. We really focus on access and keepage. It is our mission to take care of as many people in Baltimore as we can, and we also want to take care of all of you, our friends, our families. And we think we can provide the best care through our faculty. So we're really working on enhancing access. And over the last year, we've increased the total number of patients that we've seen by 30,000. We've increased new patients by more than 11,000. We've maintained a lag time for a new patient visit of 24 days. I just was at the Butler conference and everyone was complaining to me about the lag time at Hopkins being months and months and months. I don't know if that's true, but I'm quite proud of this 24 days. And we're seeing 73% of our patients within 30 days. And we're doing this by increasing the density of templates and trying to prevent no-shows and late cancellations. And you can see this average increase of 0.3 patient per session. We need to do better, but that adds up to a lot of patients. This is just showing our templating, how, scheduling, the amount of patients we schedule per 4-hour session and the amount of patients that come per 4-hour session and how that's rising. And these are some of our most successful departments. So I just want to shout out dermatology. This dotted line is 110% schedule. You're really overbooking by 10%. You can see dermatology overbooking to 140%. Ophthalmology under Lisa Shockett, orthopedic surgery, oto, rhino, laryngology, medicine going up, family medicine going up. And this is the percentage of patients seen in 30 days by our top performing departments. And this is the 80% at the dotted line, which is our target. And you can see anesthesia, family medicine, neurosurgery, OB, oncology, orthopedics, radiation oncology. We're also proud, under the leadership of Dr. Marcosi and Bert O'Malley, Our mortality rates are excellent. We're in the top 25% of academic medical centers for case mix adjusted mortality by Vizient. This just came out this week, so this is brand new data that our boards haven't seen yet. Our effectiveness is number 5 among all AMCs. Now there's also a problem that we have to work together to solve, and that's safety. That we're 99 for safety. Those are like catheter-related bloodstream infections, blood clots, procedural problems. So we obviously have a lot of work to do, and we're going to be focused together on that. Now I want to give an example of the access incentives that we rolled out that have helped hit these numbers. So in the Department of Medicine, we rolled out a new patient incentive, $40 per new patient, and a productivity incentive, $20 per work RVU if you're above the 50th percentile for productivity. And then we rolled out Power BI dashboards for every faculty member so they can monitor their RVUs, their new patients, their open encounters, and their capacity in their clinics. And we did this, one, to increase pay. We're getting behind in pay, but also to enhance access and keepage, which we need to be a viable organization and our patients need. And this is what happened in the last year. We've closed out the books. We gave $3.3 million in new incentives in the Department of Medicine alone and generated $3.5 million. So the volume paid for the incentive. Our billing went up 13%. Our worker reviews went up 13%, and collections went up 10%. So a very big success for the Department of Medicine. We also have aligned leadership. This is, of course, Bill Regine in the middle and Bert O'Malley on the left. And Bert sitting in the front here. Bert, thank you for being here. I think we're most aligned than we've ever been. We have a shared strategy for care operations and growth. We have joint reporting and joint boards. We're on each other's boards. The 20% of the budgeted margin of the hospital is reinvested in the academic mission and into clinical chair recruitment packages. And we have multiple incentives that I'll mention. The access one that I just mentioned, quality incentives, joint outpatient ventures, and I'll mention potentially avoidable utilizations. We have the first ever joint strategic plan, and this focus is again aligning with UMB and our School of Medicine strategic plan, clinical, research, education, and also revitalizing the communities we serve. And central to this clinical piece is trying to build up patients coming to us in what we call Tier 1. And this is the cancer patients, neurosciences, cardiovascular, living-related organ, West Baltimore, chronic diseases and health equity, and chronic disease like psychiatry addictions. But then enhancing or optimizing Tier 2, which is solid organ transplantation, shock trauma, pediatric heart. Dr. Law is working every day on that challenge. And we want to try to reduce what we call Tier 3. Tier 3 would be diseases that could be cared for in UMS hospitals or in community hospitals, like community-acquired pneumonia, or potentially avoidable admissions, readmissions, that I'll talk about. Now, just a very brief primer on GBR. Many of you don't know about this, new board members don't know, but we have a special Medicare waiver in the state of Maryland called the Global Budget Revenue Model. And we are paid under this methodology, not volume fee for service. And what it does is this committee, the Health Services Cost Review Commission, fixes each year's hospital annual revenue at the beginning of the fiscal year based on last year's volume, which is determined by this EC-MAD calculation, equivalent case mix adjusted discharge. So they're going to look at how severe those patients were, your efficiency of that care, and they're going to give you a capitated number that you have to hit this year. And it doesn't matter how many patients you see or the amount of services you provide. So this really helped us in COVID when volume dropped, but it hurts us now as we're growing. So the only way to survive with this strategy is we want to decrease things that we call Tier 3, things that we shouldn't be doing or where the transfer to us is futile, things with low EC-MADs, meaning they're simple, or things where there's low efficiency of care. And we want to enhance things with high complexity and high efficiency. An example would be a living-related kidney and liver. Only Hopkins and us do this, and we have the best outcomes in the region, and a living-related, a donor and a recipient come in together for a 2-day stay. We need to do more of that. And we need to reduce things like potentially avoidable utilizations. Now, what those are is those are defined by GBR as these diagnoses that shouldn't be readmitted, even if they're seen at Hopkins, or they're seen in our clinic, or they're seen in our hospital. If they come to us, we're penalized for that readmission. So we have to take care of these patients in a more holistic way. And these are the targets that GBR has set for a visit after the patient is discharged. So under the leadership of Rod Taylor, Jeanette Gibbs, we've created this program as a partnership with UMMC and our practice with incentives that those types of diseases that I described, patients with those diseases are identified in the hospital. We get a specialty consultation to educate the patient, get them the right drugs. We want 100% med to beds. Before they leave the hospital, they have their prescription in hand. We then coordinate them with a navigator. We schedule a visit in 7 days or 14 days, and then we overbook them into clinics to avoid ER visits. And this is launched, and the last 2 months we've had our lowest PAU. And there's incentives. We're actually paying $200 per visit for those PAU overbooks. So these are all the incentive plans that we have targeting these priorities, and I just want to thank UMMC, UMS, and BERT for investing in the faculty and investing in these important programs to, one, improve compensation, but drive us in the right direction towards excellence. And again, I'd mentioned these issues of shared leadership, but I also want to mention we're focused on burnout as well. When we start filling your clinics, you know, I hear from all of you, and I've done clinics for most of my life, and I know how frustrating it can be with overbooks, but we're trying to work on solutions. And one thing is we've invested in partnership with UMS in an AI-based scribe program called DAX. And this is launched with 50 of our providers. I actually went to clinic with Dr. Allen and Dr. Hong and watched them do this. It was amazing. And we're also developing student MA scribe programs. And me and Dean Michelle are working on a master's program that could include scribing. And I just want to also mention that we have physician leadership across all operations. We have engagement, which is key to preventing burnout. So I'll close by talking about community. You know, Chancellor Perman, Bruce Gerald, this has been a centerpiece of their leadership of UMB. And we don't want to just be a receivership hospital for the ER patients and transfers through shock trauma. We want to reach out in the community, engage in healthy living and preventive medicine. And so under Issa Davis' leadership, sitting in the middle, we are launching in partnership with Tim Regan a 17,000 square foot community health village, partnering with our community to improve access and meet needs. And these are some of the services. Dean Reynolds is partnering with 2,000 square foot, 10-chair dental clinic in the site. We're very excited about that, and you can see all the programming. We are trying to get more engaged in the community under Issa Davis's leadership with Maternal Health Awareness Day, Engage with Heart, a block party we all went to. It was about 100 degrees. And we had an incredible mobile health conference, and Councilwoman Felicia Porter is sitting in the front who helped with this. And we're very excited. This was organized by Issa Davis and Chuck Callahan, and we had more than 24 organizations participate in this.
To talk about the importance of mobile health and access to care, Councilwoman Felicia Porter brought us to a West Baltimore grocery store.
People often ask me what mobile health is, and my definition is bringing health care and public health into the neighborhoods. And so that can be a number of things, from bringing a grocery store back into our neighborhoods, bringing screenings for non-communicable diseases like diabetes, cardiovascular disease, that are really challenging health outcomes in our communities, bringing it back to our community. And when we talk about mobile health, we understand that access is such a pivotal issue in the city of Baltimore. We have 4 major public health institutions, and we have some of the highest chronic healthcare outcomes surrounding our hospital institutions.
Mobile health vehicles like this one will play an important role, bringing doctors and nurses into the community. But policies and institutions must be aligned to have the greatest impact.
As a government leader in the city, it's my job to make sure that not only we bring stakeholders together like University of Maryland and Care First and some of our faith-based and community-based organizations, but it's also making sure that our policies reflect health and public health within our city of Baltimore. So when we talk about transportation needs, it's also going to make sure that people have access to safe and desirable environments, and also making sure that they have access to healthcare as well.
To develop a long-term strategy, stakeholders from across the region came together in March at the Mobile Health Consensus Conference hosted by the University of Maryland.
And so it was a convening of about 80 to 100 stakeholders developing that mobile health strategy. It was an amazing experience, and it's something that for me as a local legislator and building healthy communities, that's something that I'll be leaning towards, not only just the policy, but also the convening body as well.
Councilwoman Porter, thank you for being here and for your leadership. I had hoped you'd wear that shirt, Black Girl Magic. It's been a great year for philanthropy. 67 million raised under Heather Culp, Kim Morton, and Lindsay's leadership, which exceeded our goal by 7.2 million. Is Britt Kerwin here? This is for you, this slide, Britt. Britt has been tirelessly fighting for the University of Maryland Medicine logo and brand, and we're delighted that this has rolled out for the first time with our foundation, our philanthropy foundation. So we have many Board of Visitors here, and I just want to appreciate Michael Greenenbaum, who's stepped up as president of the Board of Visitors, Gary Atman, who's here, David Clapp, John Cole, Troy LeMail-Staval, Dana Martin, Chris O'Connor, Linda Robertson, who's here, Marcus Wang, George Kochman, Harry Oken, who hosted us on the Eastern Shore, and Bert O'Malley, who's now joining as ex officio, who will be part of our Board of Visitors. And thank you to all our Board of Visitors who are here right now. These are endowed professors for this year, one of the highest honors of the university, and I'll just let you read their names, your colleagues, friends, and the people we all admire. Congratulations. Faculty honors, the Distinguished University Professors from the School of Medicine is the highest honor bestowed by President Jarrell and UMB, and I recognize my predecessor, Dr. Reese. Congratulations. Bill Regime, David Weber, and Steve Kittner, congratulations. And we've done very well as a faculty, top 100 women, healthcare heroes, influential Marylanders, the Bailey Ashford Medal for pioneering work in tropical medicine. And we are going to have anatomy lab ribbon cutting ceremony that we'll close with, and we want to celebrate the career of Dr. Claire Frazier, who was inducted in the National Academy of Science last year, and that will be an event October 8th. I do want to end with a recognition of our most awarded faculty member, Adam Pouchet. Look at these, the Golden Apple Graduation Award from our medical students, 5 Student Council graduation honors, 9 teaching commendations, 3 Distinguished Lectureships Award, Board of Regents Award for Excellence. I don't think I've ever seen.
I think Adam has been a phenomenal educator for many years. He really is the sort of the face of the school when the students first get here. He's the first faculty member that they are really getting to know in a professional fashion for a long period of time. And he really takes them under his wing from the very beginning. He is someone that is enthusiastic about teaching and about what he teaches and about the students in general. And they really love him for that.
His style of teaching is very calm, very comfortable. He's very confident, very knowledgeable, but he also makes the students comfortable, and comfortable in such a way that we feel excited to learn, but also comfortable enough to ask questions. He's just a wonderful teacher, wonderful mentor. I really look up to him.
I think one of the keys to being a good educator is remembering what it's like not to know something and being able to approach the delivery of material from the perspective of not knowing, so that you can deliver in digestible components that are relatable to the individual. And to do that, we needed a renovated facility. One of the major components which we can see throughout the lab is the advent of examination lights, surgical lights at every table. And so this allows us to bring an operating room-like experience to the first year students studying their basic sciences. Every station is equipped with touch panel computers, and as we move into the future and have augmented reality, point of care ultrasound, all of those components will continue to be advanced in a space like this because we now have the power infrastructure to support that technology. We have the educational tools in the new design to be able to support whatever is the next emerging medical intervention or educational intervention.
So I think we've had a great successful year. It's not the strongest of species that survived, nor the most intelligent, but the most responsive to change, and I think you've seen a lot of change. If you're watching the bear, I love to lead with urgency, and from the bear, every second counts, let them rip. And so I think you all have done that. I just want to thank all these people that put this together, these different educational videos. What a talented group of people we have here. And I want to thank Chris, JT, Kevin, Chrissy, Lisa, Wendy. Wendy got COVID this week and still managed to make slides 24/7. I think it kept her awake, so it actually improved her productivity. So I just want to thank you all, and I apologize for going a little long, but I'd ask our faculty we have to be a little less productive next year and we can shorten this event. So thank you all, and I'll see you across the street.